a new framework for measuring RCM success, insights from Denver Health. On behalf of Becker's Healthcare, thank you for joining us today. With that, I am pleased to introduce today's speakers, Jacob Collins, Associate Chief Financial Officer at Denver Health, and Jeff Becker, Vice President of Portfolio Marketing at FinThrive. Jacob and Jeff, thank you for being here today, and I'll now turn the floor over to you to get us started.
Thank you, Lexi. And thank you, everyone, for joining us today. We appreciate your interest in learning more about the revenue management technology adoption model that we have created together. Over the course of the next 60 minutes, we're going to take a step back and sort of look at the state of revenue cycle management today and why we thought that it was so important to address the unmet need of providing market research on digital transformation initiatives and revenue cycle and the core problems that we're collectively trying to solve with technology, and start to shed light on what's working, what's not, and surfacing that information up to the broader market for the benefit of everyone. From there, we're going to move into a introduction of revenue cycle management technology adoption model, the actual underlying data elements that we gathered to create it, the methodology, the demographics and firmographics of the people and organizations that make up this model. And then we'll go through an actual breaking out staged representation of what this proposed model looks like. At that point, we'll move to a sort of lessons from the field session. Jake will take us through Denver Health's experience with the revenue management technology adoption model, how they're using it, how it's benefiting them, and then we will close with a moving forward session on what does this mean for the industry, what does this mean for other revenue cycle leaders that are looking to maybe challenge or validate their technology strategies as we look into budget season and 2024 investments. So from here, I will turn it over to Jake, and you can take us through the first portion of our session today, Jake. Thank you.
Thanks, Jeff. Appreciate it. Hey, everybody. We'll lead with, I would say, some of the challenges, right? Some of the biggest pieces for us are that, as revenue cycle leaders, we're facing sustained negative margins over the course of the past couple of years. And as a result, traditional revenue growth and improving your revenue, I would say, from an organizational level is becoming much more challenging going forward. Moving to the next slide, of course, we have some additional pieces that are, I would say, headwinds to revenue growth, right? We're combating reduced clinic volumes. Many of us are seeing our ED and our outpatient volume drop over the course of the last year. We are still combating, I would say, staffing shortages, and that's both on the clinical side and the revenue cycle side. Coders, billers, collectors, those things, they're harder to come by. And then, of course, the third component of that is the ending of the PHE and what that means for many organizations that are going to be impacted, the changes of the patient population and what that means for, your resulting revenue. Coupled with these challenges is, I would say, a focus on healthcare consumerism, right? Our patients and our populations are much more technologically savvy. They're looking at quality, they're looking at convenience, and they're looking at cost, right? They want to see what their out-of-pocket estimate is the majority of the time. They want digital and online tools. They want modern payment options, and that's another component that I would say the current revenue cycle leadership is facing and one of the challenges that they have to navigate through. On top of that, we see, I'll just say, an army of new entrants into the digital healthcare space, right? We've seen 79% year-over-year increase in digital health and funding, a lot of new organizations, a lot of new partnerships, and a lot of new, I would say, techniques to capture patients, to work with your patients, and to sustain your patient population going forward has been happening over the course of the last 2 years. And you have to couple that with the challenges that we spoke about in the previous slides. I guess is the main takeaway. Moving to that next slide, Jeff. for us and for healthcare leaders, our main strategic objective, at least from the RCM perspective, is that increase in revenue, right? You can see over the course of this strategic survey from 2023 that increased revenue, what we led with is number one, right? And there's three, I'll say, headwinds, cost reduction, the patient experience, and staffing shortages are things that the modern day revenue cycle leader and what all of our leaderships are facing now in this environment. So kind of flipping it over, how are they going to do that, and what we're going to see with that is something that Jeff's going to talk about a bit.
Thank you, Jake. So sort of piggybacking on that, we understand that there's unprecedented financial pressure on health systems today, facing staffing shortages issues, visit volume reductions, an uptick in new entrants to the market vying for patient loyalty and vying for those remaining patient visits. And so when we talk to health system CFOs to start to understand, how are you planning on addressing those issues? What are the key initiatives and objectives and investments that you're going to be making to address some of those challenges? We generally don't hear, oh, we're going to open new facilities, we're going to stand up new service lines. We don't hear about traditional revenue expansion strategies that we might have heard about in 2019, 2018, 2017. Instead, what we hear is a strategy that largely boils down to RCM technology plays. Almost 80% of the overall initiatives that we're hearing are focused in some way on optimizing, implementing, maximizing the utilization of RCM technologies. And so it was in this environment that we stepped back and we started asking ourselves and our customers, how do you know that the investments that you're making and even the optimization work that you're planning is well targeted and is going to deliver the outcomes that you need them to deliver? Because in this sort of time of financial uncertainty, we don't have the luxury of just iterating through pilots and really just resulting in pilot fatigue. It's important that we start to bring together a collective voice of RCM financial leaders and provide sort of a bullhorn to that voice to say, this is what's working here, this is what's working in aggregate across our industry, and this is the path forward that we should start taking in order to see a more systematic approach to digital transformation in our spaces. So the RCM technology adoption model was designed from the ground up to start answering some of those very questions and to start addressing some of these common concerns from RCM leadership. So with that backdrop in place and really understanding sort of the industry that we were thinking and the core stakeholders that we were thinking that we wanted to aggregate strategy and perspectives and voices and start serving with RMTAM, the Revenue Management Technology Adoption Model, let's jump into the actual model itself, and we'll start to unpack what it is, how we built it, and what we're thinking as far as deploying this to the market. So the underlying research hypothesis here was that the industry lacks an RCM-focused technology adoption model to support digital transformation initiatives. And adoption models in general aren't new to the healthcare IT market at all. I think many of us remember the HIMSS EHR adoption model that drove a significant amount of technology implementation and optimization work on the clinical sides of our business as organizations moved from physicians entering paper orders or verbal order readbacks to leveraging EHR-based CPOE systems, nurses starting to adopt barcode scanning at the bedside for medication administration. And there's across the organization, there was a whole host of different capabilities that were deemed important in the EHR adoption model and drove overall adoption across these health systems. And when we step back and look at where is the strategic playbook for revenue cycle leaders? Where is the thought leadership and the research guiding revenue cycle technology decisions? It just wasn't there. And so to address that unmet need, we started this process in the beginning of the year, and we wrote a survey that encapsulated more than 100 technology segments. As Jake had mentioned in earlier slides, there's a whole host of startups and new entrants, even just in our revenue cycle space, that are funded startups bringing solutions to market. And what we really wanted to understand was where was the value? What was delivering value so that we could cut through and really boil down to where the most value was for revenue cycle leaders. So we surveyed 100 unique organizations. Our firmographics and demographics look really nice. We have good distribution from director, VP, CFO, and CRO levels across these organizations. Good distributions of core EHRs between Epic, Cerner, Allscripts, Meditech. Net patient revenue and total acute bed size is also well represented. And in aggregate, through this research, we have compiled 26,000 unique data points from health system financial leaders on the technologies that matter most and the correlating financial performance for those organizations. And so we're going to walk through what that looks like right now. So when we initially started analyzing that data set, the first thing that we wanted to do, or the first piece of information that we wanted to look at, was perceived value across these technologies that we surveyed on. So as I said, we surveyed on over 100 technologies. We wanted to have the respondents indicate which technologies do they see as mission critical. I could not run my revenue cycle without this in place. What's high value? What's moderate value? What's minimal value? And even what's no value, or something that they wouldn't consider within the scope of their revenue cycle processes. And so with that information, we set about building a technology adoption model that scrapped all of the technologies except for those that were deemed mission critical and high value. So this is a really focused adoption model that really only looks at mission critical and high value capabilities that revenue cycle leaders are telling us should be prioritized in technology investment decisions. The next thing that we wanted to understand, once we had that subset of technologies, is we really wanted to understand how well adopted they were in the markets today. Going into it, I think the perception would be that mission critical technologies are probably all broadly adopted already. But in fact, what we found was that there's a great distribution of adoption across the market, even when it comes to mission critical technologies. So we segmented those technologies based on respondents answering whether they had those in place today or not. And what we found was that we could nicely segment the market between technologies that more than 80% of the market was already adopting to technologies that less than 60% of the market was adopting. And we segmented those into 10% buckets to get a segmentation of the market. What we found when we did that was that even in that tranche of low adoption technologies, there are still mission critical capabilities that are emerging technologies that health system CFOs still see as mission critical or must have capabilities. And so we were excited initially at the model's ability to identify emerging technologies that are differentiating themselves from the broad base of startups and new technologies entering the market. And so when we step back and look at what that initial volume of market research looks like, what we'll see is the remaining technologies that these leaders told us were mission critical or high value capabilities, segmented based on overall current market penetration. So you can see table stakes capabilities like eligibility verification and clearinghouse capabilities. But then on the right-hand side, you can see some of the emerging capabilities where there's lower levels of adoption, but just as high perceived value from these leaders. Insurance discovery run pre-visit, automation through the prior authorization process, automation through appeals workflows, some newer capabilities coming to market and really differentiating by those that are using them. So with this model in place, the next thing that we wanted to be able to do for health system leaders is say, we are going to create a 5-stage model that helps organizations plot themselves and benchmark their technology utilization against their peer group, and then plan a path forward. So in order to do that, we needed to identify where you stand today on your model. So we needed to create an intake assessment, and we needed to create a way of delivering a benchmark on where you stand today. And so the way we're assigning individual organizations to a stage within this model is by using a mechanism wherein if you're currently deploying 90% of them, if you're currently leveraging 90% of the mission critical technologies in that stage, and you're leveraging 50% of the high value technologies in that stage, we will assign you to that stage, so long as the same holds true for all prior stages. And by taking this approach to assigning individual organizations to stages in the model, we find a nice segmentation of respondents across the overall RCM technology adoption model, wherein we look at this as a forward-facing model. A full 43% of the market sits in stage 1, and only 3% of the market sits in stage 5, where we're seeing broad use of all of the technologies in 1, 2, 3, 4, and 5. So when we pull this all together, we see the final architecture of the revenue management technology adoption model. 43% lie here. This is the really what we're considering the baseline of the industry, the starting point of digital transformation initiatives. And this means simply that these organizations haven't adopted 90% of the mission critical technologies and 50% of the high value technologies within that stage 2 segment. One of the things that we really like about the distribution that we see here is that there's a large proportion of the market, nearly 80%, that would benefit from this research, having fallen into stage 1 and stage 2. But collectively, our stage 3, 4, and 5 respondents still do represent a large subsegment of the market, so it generates quite a bit of data. There's a good bit of information within those respondents that we can pull out and start analyzing and understanding and curating a path forward. So the last thing that we wanted to do is really understand if there was a correlation between technology utilization and overall financial performance among these organizations. And coming into the assessment, we presumed that there would be. Revenue cycle leaders generally will ensure that they're investing in technologies where an ROI study justifies the deployment. And so if you're studying financial performance in mass, the hypothesis would lend to that you'll find financial performance improvement in aggregate when you start looking at technology adoption profiles more broadly. And what we found, in fact, was that when we compared the vendors, or when we compared the health systems that were representative of our stage 1 health systems versus those in stage 5, there was a significant uptick in overall financial performance in a number of interesting areas: point of service collections, denials rates, AR days and AR days over 90, overall bad debt, and cost to collect saw double-digit improvements in overall performance. And so we were excited to see that there is true validation in the precise deployment of technologies in a way that in the way that these organizations have approached has yielded overall performance improvement financially. And so this was really the bringing it all together component of the analysis for us. We looked at really all of the technologies we could think to look at when we started this survey. We moved through an analysis component to really boil that down to those that are just mission critical and high value. We looked at how that trends out from an adoption standpoint. We looked at how that trends out from a financial performance standpoint. It checked all of those blocks for us. We were happy with the performance. So at that point, we went to our internal team, our FinThrive advisory board. It's an advisory board comprised of 27 strategic health system financial leaders. We presented it to them, and then nearly 6 months of follow-on work ensued, wherein we had these organizations run through the intake assessment. We had these organizations be our beta recipients of the readout of these assessments, and we really dug in together to iterate and optimize and refine the approach that we're taking with this model, so that when we bring it to market, it's purpose fit for the job that it's been designed to do, which is just provide some overall strategic research to help health systems carve a path forward through revenue cycle digital transformation and modernization initiatives. So at this point, with a clear understanding of where we are from a deployment standpoint or development standpoint, the next thing that we really wanted to do was just take you all through what one of those readouts looks like. So we've put together an example readout so that you can understand on the receiving end of the technology adoption model, you've done an intake assessment. The model has calculated your current stage and where you fall. We want you to understand the experience that we've designed together with that FinFab Advisory Board and the readout that would be then presented. And Jake's going to walk us through a good bit of how he uses this and how this information has created value for him at Denver Health. So again, when we think about the current state of revenue cycle leaders, we know that technology investments in revenue cycle have survived much of the cost-cutting initiatives that have plagued health systems and more broadly. But RCM leaders tell us that it's difficult to measure overall financial impact of individual point solutions on the RCM tech stack. That maintaining, when we work with health systems, we tend to find anywhere from 20 to 40 bolt-on point solutions in place in any given organizations, and they'll tell us it's expensive to maintain. That's 25 contracts that I need to renew every year, 25 data feeds that my IT department needs to maintain every day. And in many cases, those offerings are duplicative in capabilities and functionality. And so in general, there is a move toward vendor consolidation, vendor elimination, leveraging your EHR where there are native functionalities available, and then expanding out with strategic partnerships to fill in any gaps there. And so we wanted to be able to help health systems really understand what those strategic gaps were, so that we could ensure that we're delivering insights to the market that is forwarding our ability to collectively improve. So when we deliver these readouts, the first thing that we present is your overall stage. And so the first slide in that deck will look exactly like the one that we're seeing here. These are the stages of the RCM adoption model. After the intake assessment is completed, the adoption model will generate a stage for that organization, and it'll indicate that here. Along the individual columns, you'll see anywhere where you've identified that this technology is in place today, where it's not in place today, and we'll gather that information and give you a sense of your overall benchmark as compared to your industry peers. Jake, when we presented this at Denver Health, what was your initial perspectives on your benchmarking study?
Thanks, Jeff. I would say that the initial perspective was that it's exceedingly helpful, right? It lays everything out in terms of the appropriate buckets. I think for me and for my initial review is how do I get from stage 4 to stage 5, right? So if there are certain things in whatever stage I'm in, what are the specific components and what are the specific pieces of technology or processes that I need to work on, I need to plan and partner with from an organizational perspective to get to that next level.
Very good. And so I think that does a nice job of really very clearly laying out where you are today and where your peers say there is additional opportunity, mission critical capabilities that the revenue cycle peer group is highlighting is important that you don't have in your tech stack today. So the next piece that we deliver as part of a readout was actually the byproduct of working group sessions with our FinThrive advisory board. And in those sessions, one of the things that really came to light was that it's one thing to do an audit of overall technologies that health system financial leaders might deploy, but it would be much more useful if we could map those back to the critical processes within revenue cycle managed that they support. Financial leaders wanted to understand where they were potentially under supporting core processes within their organizations so that if they couldn't do everything at once, they could focus just on a core area, improving that process and still having an outsized impact with their technology investments on their overall organization. And so the critical process audit delivers just that. This is an audit of the technologies that you've identified having in place today. Dark orange is a mission critical, light orange is a high value, and then dark gray are capabilities that you're reporting you already have in place. And what this allows us to do is really focus the conversation on the areas that you could potentially focus and really have an outsized impact on improving your financial performance as an organization without stepping back and looking at the technology adoption model as a laundry list of capabilities that you have to deploy immediately. Jake, when we went through your critical process audit, what was that experience like for you? Was that eye-opening, or did that shed light on things you hadn't been thinking?
No, I would say it was very eye-opening. I think the previous slide, it can almost be overwhelming. It's great when you break all the processes down, and at least from my perspective, right, we want to be able to do everything to improve the organization, right, across all of the processes. The reality, of course, is that, between resource constraints, time constraints, vendor relationships, or, IT constraints, you can't do that, right? And so taking these processes and then, laying them out to say, all right, we're going to focus on these, 4 things across the entire revenue cycle process spectrum to get us to the next level and to track to, let's say, stage 5. It's going to help us as an organization, and it's going to be a clear roadmap, not only for me, but, tactically for my directors and managers, and then, of course, upstream from me, so that they can have a line of sight on the budgetary impacts going forward.
Very good. So the sort of culminating element of the adoption model really looks at modernization planning. And so what this does is any technologies that you indicated on your intake assessment were not deployed today, but that were in your roadmap for the next 12 to 18 months, those are highlighted in orange here. So circled in orange. So what the modernization roadmap does is it starts with the technologies that are already on your own self-identified roadmap. So you can see those alongside the output of the adoption model and really understand of the things you're planning to implement, of the things that the model is recommending for consideration, what is already on your roadmap versus what are sort of net new recommendations that this model is proposing based on that data set. And so I think that this is one that we've had a lot of conversations about the look, feel, and layout that we might want to take with a modernization roadmap like this. Some organizations like to see this broken out into a multi-year. Sometimes when we talk to organizations, they'll say, no, I would want this all in year 1. I want to get there now. And other organizations will look at the same assessment and say, that's 5 years worth of work for my team. I would want that scaled out. So within the adoption model readouts, we really have a conversation around this slide. And one of the nice things about the readouts themselves is that it's a conversation. So these all can be customized and pulled and rearranged in ways that make sense for your organization. And that's what you ultimately get as the result of that readout. I'm curious, Jake, if have you used your modernization roadmap, the work that we did together? Is that something that's been of strategic value to you?
We have, and I think you spoke a bit about it earlier. Is that it's vendor agnostic, right? So if you have the internal capability in your EHR to do some of the components, you can arrange that. And then if you need to go out and, let's say, go to the market and partner with somebody on a specific component or a specific area, you can reach out to your vendors for, I'll say another piece of it. But either way, the ability to move those components over the course of, a 1 to 3 year period has been very valuable for us.
Very good. So that really is the conclusion of the framework that we've established together, the work that we've done as an advisory board to bring this to market together, and the sort of a overview of the readout that this model introduces to the market. So some closing thoughts on moving this forward for the industry's consumption. Jake, I'll let you take it from here and just kind of give everybody a sense of why it matters, how they should be thinking about this in their own organizations.
Yeah, thanks, Jeff. I would say that on the left-hand side are three big things that's kind of all in the why it matters component, right? For me and for us, it's, having a nice baseline and the standard of where we want to go as an organization, what the market is doing, what the industry is doing, and having a way to approach those areas in a systematic process. It's invaluable to have that kind of roadmap, right? The other component, and I think I alluded to this earlier, is that it's agnostic, right? Some of the components you can do yourself, some are going to be vendor partnerships, and some could be somewhere in between, right? Where you could start out internally, figure out that you can't do it, and then determine that you need a partner. But either way, the process component exists so that you know that you need to improve, let's say, whatever that process is, right? Predictive denials, right? If you can't do that component internally, you know that at some point you may need to seek that support elsewhere. And then the other component that I would say that I find valuable is that it's peer reviewed, right? So every organization is almost an N of one, right? Everybody has their own different way they do things. They have their own footprint, their outlay, their technological stack, and their vendor overlay. And so it's going to take best practices that have been peer reviewed and say, all right, this is kind of where you are. This is how you're going to get to where you need to be going. I guess I always say we will get there, right? And getting there is the next phase, right, in your stage, right, or the next stage for the organization.
Very good. And so that really brings us to the conclusion of our prepared content. We expected that there would be a good deal of questions on the model. We know that we're introducing new concepts here. So we've allocated a good bit of time to working through any questions that anybody has. We're here to stay on till the end of the hour. So Jake, thank you for joining us today and walking through this. And we can now open it up to overall Q&A. Oh, and actually, before we do that, the one closing thing that I wanted to cover, if anybody is interested in working your way through the revenue management technology adoption model for your own organization, this QR code will bring you to the intake assessment. It's a self-service model. You can work through the intake assessment yourself, and then we will work with your organization to find a time to deliver your readout. So this is available to everybody. Go ahead and check it out, and now we can open the lines up for Q&A.
Fantastic. Thank you, Jacob and Jeff, for a great presentation today. And as we've said, we'll now begin today's question and answer session. You can submit any questions you have by typing them into the Q&A chat box on your webinar console. Let's get started with the first question. This one is geared towards Jake. What was the intake assessment process like? How much time and effort should I plan to complete it? And was the readout valuable enough to warrant the effort?
No, that's a great question. I would say that it was, like Jeff, a spreadsheet document that we filled out in online form. And then, it took, 3 hours, 2.5, 3 hours. For me and my experience, I would say that the effort or the level of effort was infinitely worth it, right? It helps having conversations as it levels below me and at levels above for where we want to go as an organization. And it's, at times there's a good I hate to say a good picture, right, but a good roadmap that you can see for your leadership, where you want to go.
Great. And this next question is towards Jeff. Are these assessments truly free of charge, and how is that viable for your business?
Yeah, they're free of charge. So the adoption model intake assessment is self-service. Anyone can come complete an intake assessment. The readout deck is fully automated, so the process of pulling all of these pieces together. We'll do a short pre-readout call with the submitter just to make sure that we're crossing our T's and dotting our I's. And then it's really up to that organization on who they want to invite to the readout. We find some organizations it's really just the CFO or the VP of RCM. Other organizations will bring the directors of all of the financial departments. But these are generally just a 30-minute readout call. The slides that we presented here as what the readout looks like, it's only 4 or 5 slides. It's largely conversational. It's a very light lift for our organization. And more importantly, it is value additive for our organization. FinThrive is a new organization. We were founded a year ago as the culmination of the merging of Pelletas, nThrive, and TransUnion Healthcare. But the name FinThrive is a new name in the industry. And so we want to bring value to this industry. We want to do that in a way that is strategic and genuinely value additive. And so it's worth it to us to be there and being a helpful and strategic partner to these organizations.
Thank you, Jeff. And will the model be updated over time, or will it remain static?
That's a great question. We've been having that very conversation with our FinThrive advisory board. We will update the model as intake assessments come in. We'll validate new inputs and add them to the model. And then on some level of sequence, whether it be probably annually, we'll publish an updated view of the model so folks can see as the industry is changing, as perspectives on technologies are evolving.
Great, thank you. One of our audience members wonders if this has been done with a provider in the outpatient setting, and if so, what specialty or sector?
That is a great question. So the short answer is no. This was largely focused on hospital and health system financial leaders. There has been a large interest in an ambulatory only carve out. It is on our radar. It's not something that we've moved forward today, but if there is interest in this audience, do please feel free to reach out to me. I would love to have some conversations about the initial survey design and just validating the approach that we would take to build an appropriate ambulatory carve-out.
Our next question is, do your results show more about the demographics and payer mix of the hospitals as much as purely adoption of technology? Hospitals with positive operating revenue can afford more tech, says our participant.
So that's a great question too. That came up regularly on through our FinThrive advisory board beta testing, a number of our advisory board or safety net hospitals. So we did 2 things. One was as we were going through beta testing, we did a secondary safety net only analysis of health system financial performance, health system technology adoption. And we were expecting to see correlations in the safety net space specifically, between lower financial performance and lower technology adoption. And we were floored. We found just the opposite. A disproportionate number of stage 4 and stage 5 health systems are safety net hospitals. And so obviously we wanted to understand that, and we started interviewing the safety net hospitals on our FinThrive advisory board. And what they told us was that when you're running a negative operating margin, you really can't afford to let manual processes persist where a larger, more profitable health system could ignore that problem. A safety net hospital needs to get right on that and make sure that they're addressing those issues and really run a truly optimized tech stack. And we were seeing that in the results where these safety net hospitals were disproportionately leveraging technology. And so it was one of the interesting side stories of the overall research study was that relationship between safety net hospitals and the technology stack that generally underpins them. One other interesting anecdote that came from those follow-on interviews was one of our health system lead, safety net health system CFOs was telling us that they are always talking to startups. They will pilot technology at a discounted rate, and they'll use that technology for years, and they'll lock in at a discounted rate because they're willing to be a pilot site. And so it's part of their technology strategy to adopt technology early because they'll then get a discounted rate as a result of that. And the last thing he said was writing a case study for improved operations in a safety net hospital is like the gold standard for startups, because if they can do it in a safety net hospital, they can do it anywhere. And so it brings a lot of credibility to them. So there's this win-win dynamic between emerging technology startups and safety net hospitals. And so all of that information came to light just out of the research that we did here.
Great. We had an audience member ask, did you see a difference with hospitals doing RCM in-house or using a service company?
That's a great question. So we didn't study that. So we've had a few follow-on questions about even within our advisory board about would there be value in looking at what vendors are serving what elements of this, but we didn't take it that far. It was important to us that it was vendor agnostic. So the only thing that we included in the survey was, is this fully adopted, partially adopted, not adopted, but on your roadmap for the next 12 to 18 months, or not adopted and not on your roadmap? We didn't dissect down to, are you doing this natively out of your EHR versus are you using a RCM vendor for this capability? There's certainly opportunity to extend this research in that way. We would love to see others take that and move that forward, but just because we did truly want this to be a vendor agnostic study, we didn't take it there.
Thank you. And coming away from the process, how many different technologies have you onboarded and how many different vendors?
I think that might be for Jake.
Yep.
So I'll let you take that one, Jake.
I would say currently we've onboarded 2, both from different vendors, and then we have, I will say, leveraged internal or existing EHR technology, and that's a big component of it, right? Is that, if you can do it in-house and you can do it well, put a task force together and focus on it.
Great, thank you. One of our participants noted that contract management was labeled high value, but contract analytics was labeled mission critical. Is there any reason for the dichotomy?
We saw this in a few areas where, so when we surveyed the financial leaders, there are areas where what you might think of as a foundation solution is seen as high value, but some of the secondary capabilities of that are seen as mission critical and carve outs. And so we wanted that reflected, but yeah, would agree with the sentiment. Contract management needs to be in place. Contract management, generally the capabilities affiliated with that is identifying underpayments and understanding what's happening with reimbursement from the payers. But contract management analytics and looking at to help your organization improve negotiations with the payers and really arming teams with the data and tools that they need to defend payment increases is really seen as a more valuable subset of the overall contract management family.
And Jake, could you just round us out with a general overview of how this assessment helped your organization? Did you use this for financial planning or vendor consolidation discussions internally?
So that it's actually both, right? So you're using it with your vendor management team and your vendor management structure and understanding what your financial outlay is for either vendors or if you're going to do it yourself. So both from the financial planning and vendor consolidation standpoint.
Great. That is all the time we have for today. So I want to thank Jacob and Jeff for an excellent presentation and FinThrive for sponsoring today's webinar.